Another aspect of anesthesia is to work on local anesthesia. Local anesthetics, unlike general anesthetics, are far more relevant for their well-established mode of action. Because they're not gases and are not lipid-soluble chemical for which we hardly find a selective target, we know exactly the mechanism of action of local anesthetics. You have a diagram that reviews it right here, and you also have text, being that the emphasis on USMLE Step 1 is to word appropriately 3 major steps in order for the effect of a local anesthetic. What do we recognize first on this diagram? Well, what I'm hoping you recognize with this diagram is a target that we've reviewed now several times. M gate is open, H gate is closed. So what is this target? I'm hoping I can nearly hear you tell me inactivated sodium channels. And indeed, the diagram depicts, as we had done in antiarrhythmic, the inactivated sodium channel, which will be the target of all local anesthetics. Now, local anesthetics are called RNH2 on your diagram. This means they are weak bases. And as weak bases, a critical aspect of their activity is that they need to get into the actual nerve terminal in order to work. They need to go in. To go in, they need to be anionized. So back to general principles. If they need to be anionized, what kind of pH would I require for that weak base to be primarily anionized and easily accessing inside the nerve terminal? Are you saying a high pH? One that doesn't have too many protons? If you are, you're doing fine. And you'll see that our nurses or medical personnel or yourself will have to generally carbonate the solution of a local anesthetic to increase the pH and make the weak base anionized to allow its entry. So this is always the first point to remember well for the exam. The fact that it is the anionized fraction that gets in, and as a weak base it requires an alkaline pH. Now, once inside the cell, here's the unbelievable fact to complicate our life for a board question. From within, it is the ionized form of the drug that is active. No kidding. It is the RNH3+ that is going to be blocking that inactivated sodium channel. We're in luck. Inside cells, the pH is always slightly acidic secondary to metabolism, and that slight acidity is plenty enough to make the weak base more RNH3+. Then the final aspect will, of course, be what is the actual target of the drug. And the target of the drug is the inactivated sodium channel. Now, if this is the case, let's go immediately to mechanisms, a couple paragraphs down in your book. Mechanism, what do you recognize? It is the non-ionized form that crosses the axonal membrane. From within, the ionized form is the active form of the drug, and what it does for a living is block the inactivated sodium channel. If you know this, you now know perfectly the mechanism of action of all local anesthetics. What are local anesthetics as far as chemistry goes? Well, they come in 2 flavors, esters and amides. Esters, they require metabolism by esterases. Amides are metabolized by amidases. So you're going to think, Dr. Raymon, where the hell are you going with that? It doesn't seem like much right now, but you know what you should remember of esterases? In your general principles, go and check. Esterases are genotypically determined, and there are slow and fast metabolizers. If this is the case, then I need to worry about a potential slow metabolizer building up the ester and then potentially suffering not local, but a more generalized effect of the anesthetic. Now imagine this. You're doing local anesthesia, potentially not in an emergency room with intubation material, with antiarrhythmic drugs available and all kind of supportive management. You're most likely in an outpatient setting in your own office away from a major hospital. So you may have to worry about esterase and their genotypic polymorphism. Conversely, amides are metabolized by amidases, which require a good liver function. If a patient had poor liver function, amides would build up. So what are local anesthetics? They all sound like cocaine. They all sound like cocaine because cocaine is a prototype of a local anesthetic as a sodium channel blocker. They also, in a way, all sound like lidocaine, which was itself a class 1B drug blocking inactivated sodium channel in the antiarrhythmic section. So as such, here's how you're going to always recognize esters from amides. Esters do not have an I before the cane sound. No I. Procaine, cocaine, benzocaine. Whereas amides always have an I before the cane. Lidocaine, bupivacaine, mepivacaine. If you see an I before the cane, you're dealing with an amide, you worry about liver function. If you don't see any I before the cane, you simply have to worry about slow or fast metabolizers. So let's see. If I give you a drug that's called tetracaine, is it an amide or is it an ester? I know you're telling me there's no I before the cane, therefore it's an ester. If I give you a drug like ropivacaine, is it an ester or is it an amide? Ah, there's an I before the cane, it's an amide. So for once, the chemist really has helped us in recognizing the two groups. Do so for your exam and potentially in real practice. Another aspect of local anesthetics is the nerve fiber sensitivity. Because the drug has to be inside the nerve terminal, it is very logical that the smaller the diameter of the nerve fiber, the quicker I will achieve high concentration of the local anesthetic in the nerve. Also, because I want to bind to the inactivated sodium channel, the more that the nerve is firing, the more likely I get inactivated channel secondary to depolarization. So the smaller diameter and high firing rate, the ones that are excited, are the ones that will respond first. When it comes to diameter, you may remember from your neuroanatomy that type B and C are the smallest, and as I go through type A fibers, well, I just go up my Greek letters from A delta to A gamma to A beta to A alpha to get to eventually the largest fiber. So the order of sensitivity would be type B and C and then A delta fibers first. Whereas B fibers are primarily some preganglionic efferent of ANS, I would highlight type C fibers. Type C fibers are these small unmyelinated fibers associated with dull type of pain. And I would certainly highlight A delta fibers since those are most strongly associated with sensations such as the sharp aching pain. It is pretty neat that these smaller fibers that would be firing as I'm doing some cuts or as I have some painful pathologies would actually be the first ones to be sensitive to the local anesthetic. Notice that other fibers that are more relevant of motor control, particularly stretch of muscle, would eventually also be affected. Recovery is in the obvious reverse order, with the largest one that have the least concentration recovering sooner than the smallest one that have larger amount of anesthetic in them. Local anesthetic must at all costs be kept locally, as the name indicates. That is because we know well that blocking a voltage-dependent sodium channel comes with potential side effect in any electrically active tissue. Make it two primary ones, the CNS and the cardiovascular system. Toxicity in both systems would be expected if the local anesthetic would be left to circulate in the patient's body and distribute in heart and brain tissue. So to minimize the absorption in the blood vessel, the local anesthetic is administered intramuscularly with alpha-1 agonists. Alpha-1 agonists are given to vasoconstrict, and the strong vasoconstriction in the field to be anesthetized prevents the local anesthetic entry into systemic circulation. It also allows a prolongation of the effect of the local anesthetic by retaining it within the same spot. Well, it is that decreased toxicity we're after. And if you look in your margin, you have a very important note about the drug cocaine. Cocaine, by the way, is of course still used as a local anesthetic. You'll see how in emergency room, in hospital setting, we use gels containing several % of cocaine and use these gels potentially in nasogastric intubation. So what is so special about cocaine? Besides being a drug of abuse, it is actually a drug that blocks reuptake of catecholamines. So it is not only a sodium channel blocker, it's a reuptake inhibitor that will result in increased norepinephrine in noradrenergic nerve terminals. This in turn indirectly causes stimulation of alpha-1 receptors and significant vasoconstriction. It is important to note then on the exam the lack of a need of co-administration of alpha-1 agonist when one uses cocaine as a local anesthetic. As a matter of fact, it's easy to remember that cocaine causes vasoconstriction. What tends to happen to the nasal septum of individuals who abuse cocaine, or maybe most Miami citizens, such as myself, who simply breathe the air outside in the city? Well, then you end up with septum ulceration. The nasal septum tends to ulcerate because of ischemia, infarction, and necrosis of tissue. So it is well established that cocaine is a powerful vasoconstrictor. The final point on this page and in this chapter is the issue of allergies. Now, you already know a big chemistry for allergic reactions to occur, that of containing sulfur. You remember the sulfonamide hypersensitivity? I'm hoping you do. Now, here's the second chemistry that humans are very sensitive to and develop allergies. It is structures that are related to PABA. Now, PABA is certainly not a Swedish group. PABA is para-amino-benzoic acid. And as I'm looking at this PABA, PABA is a structure that all esters local anesthetics share. Esters are esters of para-amino-benzoic acid. For instance, cocaine is an analog of PABA. PABA is well established as a chemical that tends to cause skin allergies. Dermatitis, for instance. And when I'm looking at PABA as skin allergy, you may even think about all these over-the-counter preparations that are lotions, creams, ointments, suntan type of preparation. And if you look at them carefully, they will tell you whether they contain PABA or not. PABA causing allergy tells you now that all the esters local anesthetic may be wisely checked with a test dose in order to check if our patients have a sensitivity or not to this medication. Look at the beauty of these two allergies, sulfur-containing chemicals and PABA-containing chemicals. You know what you're going to put yourself as a note in here? You're going to put yourself as a note the chemistry of sulfonamide antibiotics. Sulfonamides are very often tested on your exam for allergies, as we'll see in the antibiotic section. And sulfonamide, would you believe, not only have sulfur in the name, they're also esters of PABA. If this is the case, you could not have a better drug to be tested for hypersensitivity reaction, but for sulfonamides. Finally, at the top of your margin, you also have a note about significant natural toxins that exist out there and that are used as such, certainly not as local anesthetic. Tetrodo and saxitoxin, as shown with a dotted line, would be large molecules that sit in the sodium channel opening. As such, what they really block is not the inactivated form, hence the dotted line. What they do is inhibit the entry of sodium through an activated sodium channel. If the local anesthetic is a class 1B type of drug blocking an activated channel, understand tetrodo and saxitoxin as class 1A chemical. For the fun of the story, tetrodotoxin actually comes from the puffer fish. It's actually isolated from tissues such as the gallbladder and the liver, and as such can cause some significant local anesthetic effect as you eat this fish. This fish is a delicacy in Japan and is known as fugu fish, And unless the cook has done an appropriate preparation of the fish, well, potential significant arrhythmias would ensue. And if you die, at least hopefully you enjoyed the fish, you may not have to pay the expensive bill associated with it. Saxitoxin, on the other hand, this is a byproduct of a dinoflagellate, which is an algae. And it's an algae that is relevant in the southern US for being associated with red tides in the Gulf of Mexico. This saxitoxin, not sexy, saxy, is a toxin that is important for killing fish, making the beach stink because of all the rotten fish. And as you walk along the beach, actually, the airborne toxin can cause significant coughing, hacking, and itchiness of the eyes and so forth. So in a way, since it's the last time we look at sodium channel blockade, maybe we should have first started looking at the natural compound to realize how dangerous it would be to use the class 1 antiarrhythmic, the anticonvulsants such as phenytoin and carbamazepine, and now to finish, the local anesthetics themselves. There are other toxins out there that have other ways of working that do not have clinical correlate. But what I want you to know out of these toxins is that a physiology question on your USMLE Step 1 might very well use tetrodotoxin in its stem. You see, physiologists have long used tetrodotoxin as a ligand to bind activated sodium channels and identify for them whether an electrical activity was due to a voltage-dependent sodium channel or any other type of channel. So if ever you see mention a tetrodotoxin, which I'm going to call TTX, a tetrodotoxin sensitive ion channel, then know that what is meant by the physiologist is that this is the classic voltage-dependent sodium channel.